A questo punto inizia la trasmissione. Tutti i partecipanti sono in grado solo di ascoltare.
Buonasera. Poiché abbiamo anche partecipanti stranieri, cercherò di farlo in inglese. Se ci sono problemi potete scriverlo sotto le domande, e ovviamente non sono Sara Tomasetti, sono Venerino Poletti e farò questa lettura in sostituzione di Sara Tomasetti. Interstitial lung abnormalities, when do you consider them a disease? This is the question. And these are my disclosures. We start with the antecedent. We have some paper documenting that in the so-called healthy people, we can detect interstitial lung abnormalities by CT scan, and the most famous paper was by the Brompton Hospital Group, Copley in 2009. They performed CT scan in a group of subjects with no clinical indication, just for screening, and they detected reticulation, cysts, bronchial wall thickening, ground glass opacity, interlobular septal thickening, and centrilobular emphysema, mainly in elderly patients, in subjects older than 75 years of age. And they said that we can detect interstitial changes, or they are frequently seen in asymptomatic elderly individuals. And they said or suggested that these changes may not necessarily represent clinical relevant disease. So the problem was arised because of the use of very, very subtle investigative tools. CT scan can detect very subtle changes in the lung, even in healthy subject, as already known, for example, for lung cancer. So this is the same setting. You have CT scan performed for other reasons in so-called normal subject, and we can detect lung abnormalities. So the problem is the distinction between a patient and an healthy subject, or when some changes in the lung can become a disease. The definition of ILA was clarified in this paper in the New England Journal of Medicine in 2011. They performed CT scan, high-resolution CT scan, in smokers, just smokers with no clinical reason for being submitted to CT scan, and they defined ILA by the radiological point of view, alterations affecting non-dependent regions and involving more than 5% of the lung volumes or the lung area. So it's a clear radiological definition. Something in the lung, more than 5% of the lung volume, that can be detected using CT scan. So the definition is non-dependent changes affecting more than 5% of any lung region detected in subjects inserted in a screening program, because they started to perform CT scan in subjects inserted in a screening program from detection of lung cancer or cardiovascular disease. So these changes were defined as ground glass, reticular abnormalities, diffuse centrilobular nodularity, non-emphysematous cyst, traction bronchiectasis, and or onacambing. And these studies were performed in a large number of patients or subjects, because these subjects were already inserted in a screening program. So from the radiological point of view, we have the distinction between normal and alteration that can be classified as ground glass, centrilobular nodules, reticulation with fibrosis, with onacambing, even onacambing and traction bronchiectasis, and lesions that are less than 5% called indeterminate or with no clear aspects. What is the prevalence and what is the clinical profiles of these interstitial alterations detected in healthy or considered healthy subjects? In these 4 studies, the prevalence of ILA was around 8%. So 8% of normal subjects inserted in a screening program have as interstitial lung abnormalities. And the minority of them, around 2%, 1.5, 2%, are also fibrotic alterations, defined again by CT scan. These subjects are a little bit younger compared to patients with definite interstitial lung disease. They usually are, of course, asymptomatic, and the pulmonary function tests are normal or almost normal, with probably some reduction in the volumes and some aspect indicating presence of COPD, but again, we are around the normal value detected in what we call the normal subjects. So we have interstitial lung abnormalities in subjects that do not need medical attention because of symptoms or significant pulmonary impairment. Again, the age, this is another study by Araki and co-worker. The age is a little bit lower compared to the patient with a clear idiopathic pulmonary fibrosis, but the age is about around 58, 65, with a predominance, a slight predominance of males. But these are data collected because we perform CT scan in healthy subjects. We don't know how these values are in patients or in subjects that are 40 years of age, because we don't have screening programs in these subjects so far. Histopathology, we have few data on this. This aspect, we have this study was performed by Miller and co-worker. They analyzed lung tissue obtained in subject with submitted to lung resection for lung cancer without ILD or unknown ILD, and they found centrilobular alterations, so mainly smoking-related ILD, fibrosis, subpleural fibrosis, and even in some subjects, UIP pattern with fibroblastic foci, and also onacambing changes. And also, we already know that in smokers, we can have subclinical fibrosis, typical fibrosis with, you see here, airways enlargement and deposition of collagen with no hyalinized collagen, but with no inflammation. So we know that in this subject, we can have a spectrum of disorders varying from smoking-related alterations, respiratory bronchiolitis, peripheral smoking-related fibrosis, to typical UIP pattern. We have also the genetic background of this. And in all this study, there was an association between the presence of MUC5B promoter variants or polymorphism and increased risk to have ILA in CT scan. A polymorphism already detected in patients with IPF and the risk to develop ILA. Another recent study made the same observation. MUC5B variant is associated with visually quantitatively detected preclinical pulmonary fibrosis. And this is another recent paper showing that there are connections between MUC5B polymorphism observed in ILA subject and in IPF. They detected a new association never observed or not observed yet in IPF subjects. So again, we have some genetic background, mainly involving MUC5B variant and interstitial lung abnormality. This polymorphism is mainly associated with some subtype of ILA. The subtypes associated with peripheral fibrosis or even onicumbing and traction bronchiectasis, but with no cellular. And again, this to add the MUC5B polymorphism data, you can show that with this polymorphism, the risk to have possible or definite UIP pattern in high resolution CT scan significantly increased. So it means that there is an association, a strong association between MUC5B polymorphism and the presence of some clues indicated UIP in patients with ILA. Other data regarding progression versus non-progression and mortality in patients with ILA. So we don't know, or we didn't know, what happened in patients when they have ILA detected by CT scan. We have some data now after these observational studies. The patient with ILA that tend to progress with time, as we can hypothesize. So if you follow up this patient, at least a subgroup of patients tend to increase the extent of abnormalities in the lung parenchyma. The progression was not only associated to the increase of extension of lung abnormalities in CT scan, but also associated with the FVC decline, so with pulmonary function decline in these subjects. And you see that with progression, the decline is around 64 milliliter per year compared to 40 milliliter per year in ILA without progression and 35 milliliter per year in participants without ILA. A minority, at least in a short period of time, in a 6 year of observation, progressed to develop definite UIP pattern, as shown in these pictures. We know that MUC5B promoter polymorphism is associated not only to the fibrotic subset of ILA, but also to the progression or lung decline of lung function in this subject. So another element indicating an association between a subset of patients with ILA, of subject with ILA and idiopathic pulmonary fibrosis. ILA is also associated with an increased risk of mortality, of all-cause mortality, mainly if, of course, you have progression. And this mortality, increased rate of mortality is due not only to all causes, but also to pulmonary fibrosis. And we know that this mortality is increased in all the study published so far. So ILA is a clear risk factor for increased mortality in this subject. And among ILA subjects, imaging patterns predict the risk of progression and mortality, and these patterns are fibrosis, onecumbing, and traction bronchiectasis. We have other interesting data that can help us to consider ILA, or at least a subgroup of subjects with ILA linked to IPF patients. ILA is an independent risk for lung cancer and can be included for example, as a criteria to select subject for screening. Pre-existing ILA in subject with non-small cell lung cancer is associated with shorter overall survival. Pre-existing ILA is a risk factor for immunocheckpoint inhibitor induced pneumonitis, and also pre-existing ILA is a risk factor for severe radiation pneumonitis in small cell lung cancer. So again, there is some link between ILA and lung cancer, and not only with ILA, but mainly with ILA and a subset of ILA having fibrosis. This is a very recent paper published in Radiology. They found that using a computer-aided quantification of pulmonary fibrosis, they saw that cut percentage fibrosis extent was independently associated with worse disease free survival. So the presence of ILA with fibrosis is a predictor of worse prognosis in patients with lung cancer. And also, we have another interesting observation. Subjects with ILA were more likely to be diagnosed with ARDS compared to patients without ILA. It means that these subjects are more prone to develop acute lung injury compared to patients without ILA. And this is another important element that link fibrotic ILA, mainly fibrotic ILA, to IPF. So the question is, there is any relationship between interstitial lung abnormalities and idiopathic pulmonary fibrosis? So summarizing, we know that we have a prevalence of 8% of subjects that are around 60 years of age that have ILA. Minority of them have some fibrosis, about 1.52%. These subjects are with fibrosis have an higher prevalence of MUC5B polymorphism. They have an increased risk of mortality and due to all causes and due to pulmonary fibrosis. And they have an increased risk to develop lung cancer, to develop complications after treatment of lung cancer, and to develop acute lung injury. So the discrimination, the separation between ILA and IPF can be very difficult. We don't know now so far where the boundaries are, because the definition is mainly based on high-resolution CT scan. But we know that histology UIP pattern is UIP pattern from the beginning. This is a patient submitted to surgical lung biopsy, a patient with IPF, and we observed in this slide all the typical aspects of UIP pattern: subpleural periacinar fibrosis with patchy fibrosis and fibroblastic foci. So these aspects are typically observed also in patients with early IPF. And this patient can start as ILA and can develop in 5-7 years, typical aspect of IPF. So early IPF may present with atypical and confounding features, mainly in high-resolution CT scan. We can study this patient with cryobiopsy. This was a patient who developed typical IPF, and he had a diagnosis of UIP pattern by cryobiopsy years before. And you see here, you can see fibroblastic foci and patchy fibrosis. When you perform cryobiopsy in this subject and you have a diagnosis, you could be confident on a diagnosis of UIP pattern only if you find pleura in the specimens. And this is our experience. We have an increase of IPF, early IPF diagnosis using cryobiopsy from 2011 to 2016. Again, we know that there is an overlap of genetic risk between ILA and pulmonary fibrosis. And so ILA can be considered in this context, can be observed in elderly and not yet an IPF because of lack of time, can be an early phase of IPF if we have time to observe the development of the full-blown IPF. But when we don't have fibrosis, can be a subclinical manifestation of other non-IPF ILDs, mainly smoking-related ILDs, or a subclinical manifestation of an unclassifiable ILD. And ILA seems to be an important milestone to understand early IPF. We know that ILA is observed more frequently in elderly compared to young subjects. It is related to smoking habit, and we have a very recent paper showing that it can be related to air pollution or occupational exposure. We have an association between ILA and MUC5B promoter polymorphism, and in a subset of subjects, mainly with fibrosis in high resolution CT scan and with MUC5B promoter polymorphism, we have a progressive restrictive impairment, and we have risk to develop diffuse alveolar damage and lung cancer. But all these aspects are typically observed also in patients with IPF. And so we can say that ILA can be observed in around 7% of the general population when this population is around 60 years of age. Only a subset of patients have fibrotic ILA and then could or can develop IPF. And these are the group of patients we can consider, or of subject we can consider or as already affected by a disease. We know that progression is observed in IPF patients even if they have normal or almost normal pulmonary function test, and the first year decline of FVC is around 83 milliliters. And we remember that in ILA, progressive ILA, the first year decline is around 64 milliliters. We know that some so-called antifibrotic drugs are effective to treat patients with IPF and preserve lung function because they reduce the decline of the pulmonary function significantly. Nintedanib and pirfenidone, these are the study by Carlo Albera showing that pirfenidone is effective for treatment of patients with preserved lung function. So, in conclusion, we can say that we have some points that need to be, or issues that need to be addressed. We know that ILA can be the first manifestation of IPF, so we could consider ILA as the tumor are now considered when you perform a screening for tumors. So we will have more subjects with subclinical or not clinically relevant fibrotic lung abnormalities that can progress to fibrosis and typical IPF aspects. And we have other mainly centrilobular nodularities or ground glass that do not progress or do not belong to the IPF field. And we know that we have in randomized clinical trials, we have patients with preserved lung function, they have significant decline in 1 year, and in this subject we know how to treat them. We know that in early IPF we have a decline of around 83 milliliters per year, and in progressive ILA we have a decline of 64 milliliters, and we don't know yet, or we have some ideas, but it's not completely clear how to treat this group of patients. And these are the 4 major issues, or 5 major issues that need to be addressed. Standardized nomenclature is not yet so clear. The nomenclature for interstitial lung abnormalities, incidental CT features of traction bronchiectasis and or onacambing, are they already considered a progressive ILD or not? I think we have good data showing that this subset of subjects are already affected by a progressive ILD leading to IPF. Can histology provide useful information to discriminate between non-progressive and progressive ILA? And mainly, could be cryobiopsy used in this context? Can genetic investigation provide useful information to detect progress or to discriminate between progressive interstitial lung abnormalities from non-progressive ILA? And can antifibrotic treatment slow, stop, or reverse fibrotic changes detected at the preclinical phase? So I think we have enough time, you can put your questions or write down your question. I can try to answer. Spero che il mio inglese sia stato non così pessimo da non essere compreso. Grazie. E questi sono i ringraziamenti che voglio fare ai miei collaboratori che non solo mi hanno aiutato a fare questa presentazione, ma mi aiutano quotidianamente nell'attività clinica di ricerca.